there came the challenge of tuberculosis. TB was a major issue, and therefore, because of, again, handling of TB, and there were no specialists in handling TB, then we had the first specialization program, and that was lung and skin. And you realize lung and skin, there is no program, it is only in Kenya where you used to have a program called lung and skin, because it was purely homemade. It was made from within Kenya to be able to handle issues of TB. But after some time, this program, it has, in fact, recently, I think about 2 years ago, we were able to split it to dermatology and venereology, and also lung health. So those are now two specialization programs.
An estimated 1.1 million Kenyans fall into poverty each year. And that's because of healthcare costs. Would SHA shift UHC change that, or is there more? Or perhaps, what's the difference between a pharmacy with a blue cross and a green cross? What about cancer and the rising incidence amongst the youth? Is it just lifestyle changes, or is there more? Women's health, men's health, your children's health, the economy, this and more awaits you on Season 2 of Kenya's favorite health podcast. My name is Dr. Diana Wangari Gitau, and welcome to Season 2 of the One Health Lens podcast. Hello, welcome to the One Health Lens podcast, where we have conversations around health and related topics, making them simple and easy for you to understand. I'm your host, Dr. Diana Wangari Gitau.
And I am Dr. Simon Moshara Kigondu.
Today we have an important guest having an important conversation: clinical profession in Kenya, the state of it, the vision, what's next. We have, as I said, a very important guest, Bwana Waziri. Maybe you'll introduce yourself.
Thank you so much, Dr. My name is Honorable Albert Wagura Taiti, the current County Executive Committee member for Health, or Waziri for Health, and also the President of the Kenya Clinical Officers Association, though outgoing, because in a few months I'll be handing over the mantle to somebody else so that he can take to the next level.
Absolutely. Karibu sana Bwana Waziri.
Thank you.
Maybe before we even go to Laikipia, the vision, the work that you're doing, we'll start off with the clinical profession. Most people will be wondering, what does it entail? What does it look like? From training, what does this association do as well? Maybe you can take us through that.
Thank you so much, and I think this is a great opportunity for that, because for a long time I think this is a profession that has not been very well understood by many. Even fellow even professionals from other lines. And clinical medicine is a program that started in 1928 in what used to be called King George Hospital. That is the current Kenyatta National Hospital. It started as just a program to take care of the situation of health that was pre-existing by that time, because we didn't have, we never used to have local doctors by that time, and when as issues of health became too demanding, there was need to train a certain cadre which could be able to take care of some of those emerging health issues by then, and to be able to fill up the gap where we could have had the doctors, but because of our levels of development, we didn't have the doctors. So the program started as a certificate program, and majorly it was more practical than theory. Theory was very little, practical was more. And the people who studied clinical medicine would be expected to do simple diagnosis and also to do some simple procedures to be able to help the patients by then. This program went on, the training continued, and by the beginning, towards end of the 1960s, around 1968, that is when the diploma program started, and it was started in Machakos, and while in Machakos, in fact, some of the first students of clinical medicine, some of them are still practicing. We have still somebody like Professor Kang'ethe, who is a professor in a university in Eldoret. I think it's Moi University in Eldoret. He's still teaching. He's no longer practicing. He specialized up to ophthalmology. Then he took another line of medical education, and that is where he is as a researcher, as a professor in the university. Now, after some time, there came the challenge of tuberculosis. TB was a major issue, and therefore, because of, again, handling of TB, and there were no specialists in handling TB, then we had the first specialization program, and that was lung and skin. And you realize lung and skin, there is no program, it is only in Kenya where you used to have a program called lung and skin, because it was purely homemade. It was made from within Kenya to be able to handle issues of TB. But after some time, this program, it has, in fact, recently, I think about 2 years ago, we were able to split it to dermatology and venereology, and also lung health. So those are now two specialization programs. But we have also had other programs coming up. We have reproductive health. We have pediatrics. We have ENT and audiology. We have ophthalmology. We have also cardiology. Cardiology is being taken in a current hospital. We have quite a number of other programs. In fact, the programs today, there are over 15 different programs, specialization programs. Of course, still on the way. We because there is no profession that comes without a way of progressing. And that is where now clinical medicine found itself, all those who are stakeholders in clinical medicine found themselves looking for a way to get, because now it was at diploma level, the specialization was at what we used to call higher national diploma. That means there was no degree. So they had to look for a way of going for degree. At one point, because of frustrations, every other cadre will always try to look for a way out. Out of frustration, they had tried to approach even different schools, medical schools, to see whether they could be able to get credit transfers, so that they could be able to join medicine, and maybe at instead of joining at the basic, they could be able to join, because they had already, when you do 3 years diploma and you have done a whole year internship, and what we were doing is that in first year is normally the basic subjects, starting with anatomy, physiology, microbiology, parasitology,
They were covered physiology,
all
there
those,
are CS.
yeah, all those subjects that are normally covered at a basic level, to understand the human being and all those other things that entails in medicine. And then in second year, that is the time there is introduction of the clinical subjects. That is medicine, surgery, reproductive health, pediatrics. Then we also have community health, and also health systems management.
So you want the call was that given that there's already knowledge in clinical medicine, they don't have to start from year 1, year 2 where the basics have been covered. They can join at the point where clinical subjects have been introduced.
Exactly.
And so then the conversation was that what happened there after that?
The conversation, in fact, it was not received very well. And the argument was, as long as you want to do medicine, then you must start from year 1 all the way. And then they felt that this was not good enough. And in fact, I remember even when clinical, because they went ahead now to start a degree in clinical medicine. And the first degree was started in Kenyatta University. And when it was started in Kenyatta University, one thing is that clinical medicine did not have a faculty. So they had to rely on the same doctors. And the doctors were the same people who were saying you have to start from scratch. So even the doctors themselves, they started arguing amongst themselves. There were those who were for it, others were against it. And therefore, even the program that has started as clinical medicine degree, at a point it was changed to degree. And in fact, those who had joined, they were forced to go the whole program. In fact, they spent many years, and because majority of them were lecturers in Kenya Medical Training College, where I also was a lecturer. I have been a lecturer there for many years. Some of our colleagues who went there, in fact, we almost forgot that they were part of our staff, because they overstayed in the university. But finally, they qualified with the MBCHB and not clinical medicine. But the journey did not stop there, or the struggle did not stop there, because we clinical medicine, we were feeling that the people, we need to have an opening where clinical officers from diploma can be able to move on to degree, and that is how now the BSc in clinical medicine started. It started in MKU. MKU was among the first universities to start. Then later on, we had even public universities like Egerton University. We had even JKUAT, and we also had which other universities? We had even Moi. We also had Kemu. At least quite a number, because right now I think we have about 10 universities which are offering degree in clinical medicine. And then, of course, of late we also have had other universities providing master's programs. Same MKU, we have KEMU, we have Kirinyaga University, we have JKUAT, we have Egerton, we also have Kabarak University. Quite a number of universities now embracing, and I think they are now heading to a PhD. Some of them have done PhD, and some are taking the line of basic subjects like anatomy. Some even have a doctorate in anatomy, which is good enough for the profession, so that it can be able to grow.
So then, in terms of, and it was important to give us that context, because then when we come to practice, we tend to hear certain questions coming up. One you've highlighted to us that the training is intensive, the training at the same time allows for specialization and even subspecialization, right? So from clinical medicine, you can very well go now to masters, but more importantly, you can even have done clinical medicine, but you specialize in certain areas, right?
That's true.
So then if you're to talk about now the practice of clinical medicine and coming to the association, right? How many members, first of all, would you say either are part of the association, or how many members have basic clinical medicine practice from either diploma or degree level? What's the population?
Thank you so much, Dr. Ari. But just before that, I would just want to take you back just a bit.
Okay.
Maybe to know how this profession of clinical medicine, how it is normally run, which are some of the bodies that run this clinical medicine. If we may start with the Kenya Clinical Officers Association, this is the mother. And it was started in 1968.
Okay.
Then it was registered under Register of Societies in 1981. In 1981, the reason as to why it was registered is because clinical officers did not have a regulatory body. They did not have a regulator. And therefore, they had, first of all, to do the necessary, that is, have a formal association so that it could be able to push for a regulatory body. And that is the time through an act of parliament, that is that is the Area Act, which was which came into play in 1981, the same year. That is when we got the Clinical Officers Council under the Act, and that is the council. Clinical Officers Council is what regulates the training, the practice, and even the licensing of clinical officers. So the clinical officers have a regulatory body that they don't necessarily have to rely on any other regulatory body to be able to do their business.
Kigondu, what has been the working conditions between, first, the working conditions in terms of clinical medicine and how they collaborate with the medical doctors and the rest?
So thank you very much, Wangari, for hosting Mheshimiwa here, because the clinical officers and doctors have been working together for some time now. When I trained as an intern many years ago, my best guys were in the ward you'd find, you come in as an intern, were very few at that time, and we had very well-trained clinical officers who really facilitated our learning. And for me, that was the first learning lesson, which is one of the lessons that interns ought to learn, that medicine is a harambe, you know. The output that you are all looking at before you enter into any form of conflict is quality healthcare for the patient. Of note was that they were very good at putting, for instance, granulas, you know, the intravenous lines. So they teach you and you eventually get to know. So that's working together. Secondly, in those days when there were no, as has been aptly put in the background of having the clinical medicine program, was to fill in the gaps of that were falling through the cracks, and especially for screening, a lot of screening and early treatment, because of the numbers. Those a long time ago, the number of doctors was still few. But so the shorter duration of training and the quicker deployment of clinical officers meant that the team out there could actually take care of the population, whereby many of the clientele would be seen by the clinical officers, and those that required the doctors were actually filtered to them. Then there was still a lot of work. So the issues that come up mainly are in my view, in my long-term view, having worked in the field for some time, are economic. And why do I say this? And maybe just to solve the issues that I will raise is that Kenya as a country needs to expand its economic space. Its solution of many of the things that are happening, the Gen Z revolution and all, they are all about the economy, education and all. So once we have that pact, that is okay. So our issues are all economic. Now we go back to the issues of, there have been very good working relationship between the Kenya Medical Association and the Kenya Clinical Officers Association, especially in this time that we have worked with Taiti. As you note that both associations were established in the same year. So when we celebrate 50 years, they celebrate 50 and 60. So we are going to end up a two, in the programs that we have established, and this was demonstrated very well in the COVID pandemic when the two associations worked together. So we had a program where we trained all health workers across the country on how to manage COVID, and the board had the KCOA, KMA, the union, and other cadres, nurses, and all. And I think the output of that is out in the open, that when people work together and not focus on the differences. A lot of people focus on differences too much. That leads to stagnation of growth. So the COVID management of the different associations is another example. Come now to the latter form of working relationship, which I think Taiti here is a big member of, is a program called SEBA. SEBA is where we have use of evidence-based policy decision making. It's a program that was run by Capricorn, which involves the professional associations going out to advocate at the highest offices for healthcare to be provided, or what resources, advice of professional associations to the leadership, all the way from the top to the bottom.
Nazir, we'll have you back again, but I hear there's a big event happening in Laikipia, one of many to come. Maybe you can mention it as the final point. Then I'll, yes. What is happening in Laikipia County?
Thank you so much. I think Laikipia of late has become a place of attention, which is good enough.
Yes.
After people realize that of our goodwill. We have our governor, His Excellency Joshua Irongo, EGH, whom Dr. Kigondu has really met several times. He is down to earth person, and with very, very, very a lot of goodwill, and especially on health. In fact, his agenda number one, he says his legacy number one wants to come from health. And therefore, he does, whenever we approach him on anything, he normally doesn't give us a problem, unless it is something that is totally impossible. But whatever is possible, he will work towards that. And therefore, of late, we have had a number of national events coming to our county. Of course, in May, we had the national celebrations for the International Day for menstrual health and hygiene, which went on very well in Laikipia. Again, Laikipia has been identified for the World Patient Safety Day celebrations, national celebrations, which will be this time round will be still in Laikipia. In Nyahururu, that is the western side of Laikipia, in Panari restaurant or whatever, the resort. And this is a very, very critical for us and very important. Because when you talk about patient safety, what are we talking about? In fact, basically, we are talking about best practices. We are talking about good clinical acumen. How do we diagnose our patients? Very good history taking, very good examination of patients, very good way of identifying the very relevant investigations to do on these patients, and making sure that we don't leave a gap. And this one will come from, and that is why I started. It's good you started asking me questions about training, because everything good with a professional starts with training. If the training, you get training right, then of course everything else most likely will fall in place. So, and therefore this event to us is great, it is important, and I would want, on behalf of the county government of Laikipia, and on behalf of my governor, to really welcome all to Laikipia. All roads lead to Laikipia on 17th of September this year, that is just next week. And we really want to welcome everybody. Laikipia, apart from even patient safety, it is also very nice for tourism.
Absolutely.
Very good places, and you know, when you talk of Laikipia, people will always see. And it is a very peaceful place.
It is.
And with the best climate. And let me remind you that today Laikipia has the highest life expectancy. In fact, it's the best place to retire. If you want to live longer,
Laikipia,
settle in Laikipia.
Kigondu. Final words.
Don't settle in a central where Kigondu is.
Yes.
You know, it is very cold. You develop as varieties.
I think Wangari, you've heard it straight from the president. There is no dispute between clinical officers and doctors, because the scopes of practice are clear. And secondly, the issue of specialization. We have specializations on all sites. And maybe what I need to add is probably they need to decide among them who is the team lead. But I guess conflict comes when people go beyond their scope of practice, and when people don't respect each other. And that's why the associations try to build on the commonalities so that we work together. The big conversations that we need to have, actually, and Taiti touched on it, is on that issue of transition. They had actually transition from clinical officers to doctors. That issue, it's a bigger debate, and that transfer of subjects and things like that, that is probably a framework that needs to be worked on. I think they've done that in Tanzania. So we don't need to invent the wheel. You can always do that. And we have our champion, who is the clinical officer number 1, doctor number 1, and family physician, Dr. Joy Mugambi, who has brought us all together. And I think she's a mother of all. She arranges big things with KCOA, with KMA, and today is her birthday, so we'll wish her a happy birthday.
Oh, great! I didn't know.
She may be the key to
figuring out how to. Okay, fair enough. Dr. Kigondu, thank you. Bwana Waziri, you must come back and tell us more about how we all need to move to Laikipia.
We need everybody. In fact, Laikipia is a home for everybody.
Absolutely.
It's serious cosmopolitan.
I agree with you 100%. And next, on Tuesday, it's World Patient Safety Day. I think some of us will be there. Thank you so much, and we'll see you next time. Yeah. Okay. Thank you. And thank you for listening to us. Join us next time on the One Health Lens podcast. Bye.
Thank you.